Good evening, everybody, and welcome to our webinar tonight. My name is Jenny Pearson. I'm an Education Officer for the Primary Health Network, and I sit in Armidale in the Northern Tablelands, and I am on Enewan land. Before we do go any further, I'd like to acknowledge the traditional custodians of the land that we're meeting on tonight and pay respect to elders past, present and emerging. We have a great array of speakers for you tonight, and that's about all you need to hear from me. Please don't forget to type into the question box any questions that you have, and I'll just hand over to John Bailey.
Thanks, Jenny, and welcome everyone. I'd like to acknowledge the traditional owners of the lands that I'm sitting on, which is the Wanneroo land. So I acknowledge those peoples. Thanks everyone for joining us. We've got a great panel tonight and a whole range of really good topics to cover. So what I'd like to do is firstly introduce our speakers. For this evening, we have Dr. John Ferguson. John is Director of Infection Prevention Service and a Senior Staff Specialist at Hunter New England Local Health District. We're going to be joined by Dr. Cohen Butters, who's a Staff Specialist in Infectious Diseases and a General Paediatrician at the John Hunter Hospital and Medical Lead for the COVID Kids at Home program. We're also joined by Dr. Michelle Redford. Michelle is a GP at Blackbuck Doctors in Newcastle and a GP advisor to Hunter New England Central Coast Primary Health Network. We're joined by Dr. Joanne Wood. Joanne is a VMO with the HNE COVID Care in the Community and a clinical editor for Health Pathways. Dr. Karen Douglas joins us tonight. Karen is a GP at Terrigal and Avoca Medical Centres and is chair of the Central Coast Clinical Council for Hunter New England Central Coast PHN. Dr. Marie Puxty is a practice owner at West Armidale Medical Centre, chair of the New England Division of General Practice and chair of the Rural Clinical Council for Hunter New England Central Coast PHN and a senior lecturer with the UNE Rural Medical School of Medicine, And Dr. Mark Lowenthal. Mark is Medical Director for COVID Community Care in COVID Community Care program at Hunter New England and an infectious diseases physician here in the Hunter. So what I'd like to do now is just give you a couple of things I'd like to show you. Can you see my screen, Jenny?
Yes, we can.
Okay, so we've established a portal over the last week to assist us in making sure that we give you answers to the questions that you might have in between our regular webinars. And to be able to get to that portal, we've got the links. These slides will come round to you as registered participants. You can access it by using this link here or by clicking on the logo or scanning the QR code, which will be in the slide deck that we provide for you tonight. I'd encourage you to enter questions into the question box tonight though, so we can cover those as soon as we can. So thank you, and I'll now hand over, I think it is to John, isn't it?
That's right.
Yep, sorry, my screens are playing up. Yes, I'll hand over to John Ferguson.
Thanks very much. You're seeing my screen?
Yes.
Yes, thank you.
Okay, I'll just, All right, so I'd like to also acknowledge the traditional owners of the lands we're meeting on. In my sense, it's the Awabakal people from our district. Now, Kat Taylor from Pop Health Central Coast has provided some slides to me. Thanks, Kat. And I'll give you a quick update of our situation and then talk about a few issues that are hot topics. So Kat's put together this history there that you'll all be aware of, so I'm not going to focus on that other than to say some of these super spreading events set the records in Newcastle, and more than 150 cases from the Argyle Hotel. We had another location not listed here, which was attended by many of our intensive care staff after their Christmas party. It was a nightclub, and that then caused all sorts of bother in the hospital. So this was Central Coast epidemic curve going off the scale there, and I think this gives a good sense of where we're at in terms of looking at the number of tests in blue and the percent positivity. So we all know that the PCR resources have been exceeded, and so the test results from PCR in early January really don't reflect the total caseloads, but the percent positive really provides a great indication that of the increasing prevalence of disease. And so we've had a steadily rising hospitalisation with a slowly rising intensive care population, which thankfully has been slower than we thought. So if you look down the bottom, you can see there the percent of new cases 7 days prior, new ward admissions. We're running at about half the percentage of the previous week, and similarly with ICU. And the way we're tracking at the moment is towards the lower side of the model predictions, which is great news. So I guess everybody's still quite worried. So we're only getting a trickle of cases into ICU. This is a report that's produced weekly from a state level that's attempting to match together the cases against the inpatient registers and find out why people are presenting to hospital. And you'll see here that they've identified 612 cases since the 11th of December, representing the current wave. And of those cases, 134, well, they've excluded quite a few of those that were just ED presentations, but of the ones under focus, 234, 134 have come in for COVID care. And there's a reasonable proportion that are flagging as nosocomial infection. So we've had clusters within wards, sometimes triggered by an infected healthcare worker and then spread within a multi-patient ward. So that's accounted for about 17% of our cases. You'll see there on the right, the hospital length of stay has been fairly modest and far shorter than with Delta. So we're having hospitalised patients who require oxygen for a short period but don't progress further in large part. ICU, predominantly Omicron cases in ICU because of its incidence more than anything, but Delta is still around. And you'll see there that most of those patients have got to ICU because of that, that confirmed COVID infection in the first place. Currently, as of this morning, 105 inpatients across Hunter, New England, and I think proportion is similar in Central Coast, and average age older than the cases 64 and 71 years. And overall, from the previous analysis, they've looked at vaccination status of those cases, and you'll see there that predominantly they've had 2 doses, but more than 3 months prior. And we'll talk a bit about vaccine immunity in a moment. So just of interest, here's a case that just presented overnight to John Hunter, transferred down from Maitland. 64-year-old woman with comorbidities who'd been vaccinated prior to September, and she was being managed, having presented in respiratory failure at Maitland, and they were really struggling to keep her from becoming hypoxic. And you'll see there the diffuse pneumonitis. The X-ray on the left is from the 11th, and then the 13th, so progressing pneumonitis there. And so she's now in John Hunter and probably heading the way of ventilation. We don't know her strain type. Now, there's some very interesting analyses from the UK that have looked at the effectiveness of vaccination and boosters. So these are data from very large patient sets in the UK looking at vaccine efficacy against hospitalisation, and you'll see there that the numbers on the x-axis are the weeks since vaccine. I'm just trying to get rid of my picture off the screen so I can see the slides. Sorry, now I've done it. And so you can see there that these are patients that have had 2 doses of the AstraZeneca vaccine and then had either a booster with the Pfizer vaccine in the middle there or the Moderna vaccine there. And you'll see there that the Omicron is the circles, Delta is the squares, and you'll definitely see evidence of immune escape there with a ramp up of efficacy with booster immunization. And when they look at the overall protection against hospitalization, there's a vaccine efficacy of greater than 88% for Omicron, which really gives us a lot of assurance that boosted people are going to do okay. Now, just to finish, I did want to just mention about rats, which to the fore. So we need to use a validated sample type, and there are validated assays from TGA that through that link there. And I think we accept that rats perform very well in early illness when the PCR viral load is high. False positivity is clearly an issue in low incidence populations, but given the current incidence of disease, I think we're unlucky to see false positives, but it's possible. Indeterminate results. So there's an indeterminate result on the right there. You can see the T line and no control line, and we're told not to accept that as a positive assay. The control line indicates that there was something wrong with the specimen. We can't interpret that result. It's an indeterminate result. And we are moving more and more to limit the reasons for going on to PCR confirmation. And in large part, we're doing this for rat positive patients who are likely to require COVID treatments. Here's a meta-analysis of a lot of studies, 13 studies looking at rats, over 12,000 patients. And the bottom line here is that viral load, as shown by CT value, PCR value of less than 25, which is quite a high viral load, shows a 94% sensitivity on this range of antigen studies. And you'll see there also presence of symptoms, more likely to be positive, and duration of symptoms, importantly, less than 5 days, very likely to be positive. So rat antigens probably do reflect infectivity better than PCR. There's some initial data showing that if you're rat positive PCR and PCR positive, you're more likely to be culture positive for what it's worth. But I think the accepted wisdom at the moment is still that you're most likely to be infectious in the first 5 days of illness, whether you're vaccinated or not, and you can be quite infectious during that time. Whether you're infectious greater than 5 days is a moot point. I haven't really seen good data on Omicron as yet as to the viral dynamics past that 5-day point. So this was Kat's slide, Kat's rat slide, just tabbing you through there the different situations. So we're happy with a test result in a symptomatic patient. We're happy in someone with an epi risk factor. If there's no known contact, then perhaps you need to repeat it again. But in the current setting, most people don't know their contacts and they've got true positive results. So knowledge of epi factors is a moot point. You can see there her recommendations for other categories of result. Lastly, release from isolation. So cDNA have kept this at 10 days minimum. There is a let out if you are test negative at 7 days, but we virtually never find that. And we're now, even with rats at 7 days, you're very likely to be positive. And we don't really want to get people being tested again within a month of release from isolation. So the US have bravely moved to a 5-day cut point for return from isolation. UK and New South Wales currently are at 7 days, but within the health service, we are still wary about that, and we're trying to stick to cDNA guidance on this, and I wish New South Wales would do the same. Quarantine for close contacts. So again, I'm quoting cDNA here, which has it stratified by vaccine status, which probably will go out the window with the next version, I would say. They're saying minimum 7 days there for a fully vaccinated close contact. And I want you to be mindful of the fact that not everybody reads that textbook, and certainly about 20% of incubation periods go beyond 7 days, regardless of vaccination status. And we're pushed now to a pragmatic approach, and in Hunter, New England, we'll do that at day 2 for close contacts if needed, and then perform daily rats as a risk management to check for infection. So thanks very much. I'll stop there and look forward to your questions.
Thanks, John. I think what we might do, we're going to have a question and answer panel to the panel at the end of everybody's presentation. So I think what we might do is save our questions to the end. So I'd just like to introduce Cohen Butters. Have we got Cohen with us?
Hi, Karen. Yes,
Hi,
I should be
Cohen.
online.
Fantastic, thank you.
Fantastic. So I'm just going to hopefully share my slides here. Give me 1 second. And we'll hope that it doesn't create a computer crash. Can you see my screen there?
I can't yet. Jenny, can you see it?
No, not yet.
Just hold on 1 second.
Whilst you're doing that, Colin, I might just ask a couple of questions to John, if that's okay. John, can you pop yourself back on the screen, please?
We can see your emails now, Cohen.
That's a bit of a worry.
We've got John,
Now
just
we can
a
see your
question
slide.
that has come up.
Fantastic. So thanks so
Yeah.
much for having me along. My name's Cohen. I'm one of the pediatric infectious disease.
I'll just ask John about one questions we've got. Yep.
Yep.
We seem to have a little bit of a delay with some audio. Karen, did you want to ask that question before we go any further?
Yes, I will. I think we're having a few IT issues and we must apologise. I think having so many of us from all over our PHN footprint is probably causing issues. So again, I'll ask for everybody to take their camera off when we're not talking. But John, I was just going to ask you, there is a question here, we may as well sort of kick off the Q&A, is about when we're talking about the rats versus PCRs, one of the questions is we currently require patients in our practice to have a negative PCR if they have symptoms and need a face-to-face appointment. What are your thoughts on a negative rat versus a negative PCR in this context? So somebody with symptoms?
Yeah, I think that's very adequate, really. We can use a rat as a triage tool, for sure. It will be adequately sensitive to detect infectious patients who have symptoms, for sure.
Thanks for that. Cohen, are you there? And would you like to start, please?
Yeah, very happy to start. Thanks, Karen.
Thank you.
I'm Cohen. I'm one of the general paediatricians and paediatric ID physicians with John Hunter Children's Hospital, and I work with John. So tonight we'll talk about COVID-19 in children and the many changes that have happened quite quickly. And I'm sure, like us, you're trying to keep up. And one of the things that's amazed me about the pandemic is often that families are updating me around critical changes that have occurred during a media conference in the hours prior to speaking to them, as I'm trying to organise de-isolation for them. So things are always changing really quickly, and that's just the nature of things. So I think John's given a really lovely introduction to the epidemiology, but just to highlight, actually, young people are responsible since June of last year for the vast number of infections. You can see here, particularly in the paediatric age group, or right up to 19 years of age, over 100,000 infections throughout all of New South Wales. This is as of today. And many weeks ago, we would have had up to 500 children on our service, the COVID Kids at Home program. But with changes in the criteria, we're really trying to focus on those really high-risk patients and ensuring that they get access to disease-modifying treatments where necessary, but also ensuring they get support for their complex comorbidities where that's required. So you can see here currently the majority of our patients really sit in that 0 to 4 age group, and a high number of patients who are just neonates within the first month of life, and particularly within the first 3 months of life, including a number of premature infants. So the thing that's quite different about the Omicron variant for us is really that the infection is filtering down into the high risk population and in newborn babies particularly. So I don't really have paediatric case numbers, and I'm not sure they're really as accurate at the moment, particularly because access to PCR testing has been difficult, and has been particularly difficult for young infants, with many centres not offering PCRs, and really people being quite uncomfortable going to an emergency department for testing for young infants. There's just been changes, as you know, in terms of logging positive rapid antigen tests. And in fact, there's less incentive for children to get testing, particularly when they're not needing tests to go back to school and obviously aren't going back to work. And one of the other challenges is that many of the rapid antigen tests are not validated and clearly state that they're not for use in less than 5-year-olds. So really for that group, it's going to be critical for access to PCRs to really have a diagnosis of COVID-19. Just highlighting this paper that's just recently been or about to be published, and it's from the Sydney Children's Hospital Network. The first thing I think reading it was that it would be nice for our network to be included, but that's a constant kind of battle, given that we're looking after a large part of the state. But really their experience reflects our own experience here with the Delta wave at least. So they had over 17,000 patients less than 16 years of age with COVID up until October last year. 20% of them were asymptomatic. In some of the previous data, it's been up to 40% of kids have had no symptoms whatsoever. They had low rates of medical admission, and actually our medical admission rate locally has sat around 1%, but high rates of social admission, so almost 2.5% require admission because of family members being unwell or other psychosocial vulnerabilities needing them to come into hospital. Reassuringly and consistent with international data, the rate of admission to intensive care was very low, with only 15 of those 17,000 kids requiring intensive care, and there was no deaths during that period. So looking specifically at risk factors, and it's this paper and this data that's really changed the model of care in New South Wales for children. The specific risk factors for admission to hospital and more severe disease were children less than 6 months and the adolescent age group. And that's what we're finding. And there's really two disease processes there. In the younger children, it's often related to dehydration, inadequate input, as well as gastrointestinal symptoms with diarrhea and vomiting. And then the adolescent behave much more like their adult group, which you'll be more familiar with in terms of developing COVID pneumonitis between day 5 and day 7. And generally as a group are much more symptomatic, much more like the adults, regardless of vaccination status, with lots of frequent chest pain and dyspnea in this group, or at least in the group that we're looking after. Prematurity was a specific risk factor, and that's a bit of a worry for me, in that we're not easily able to identify those children and screen them through the referral process that's currently in place. And then importantly, a range of comorbid conditions were associated, and that's that long list of complex disorders. So in particular, chronic respiratory disease, chronic lung disease, for example, cystic fibrosis, as well as cardiac disease. Originally, we were saying asthma is a risk factor, probably a risk factor for COVID-19, but we're much more comfortable based on both adult and pediatric data that really doesn't translate, and probably the immune system in asthma is set up to be somewhat protective. So really only the severe asthma, severe end of the spectrum with frequent ICU or steroid use, ED presentation being a marker for more severe disease and need for admission to hospital. So the COVID Kids at Home program consists of a consultant, which is mostly me at the moment, as well as a paediatric registrar and a mix of nursing staff. As you can imagine, as the service has got more busy, has got busier, we are using allied health staff more, as well as some dedicated team leader nursing staff, very experienced registered nurses and specialist nurses to provide care. It's a model now in which patients are admitted and get a daily symptom checker sent out to them. They record their symptoms, and that comes back to us, and that's stratified into moderate or high symptoms or low symptoms. If any patients flag symptoms that are considered to be risk factors for severe disease, then they'll get a phone call either by nursing staff or by medical staff for a review. And the real focus of the program is to prevent mortality from COVID-19, but we recognise that that's extremely rare. But we're really focused on supporting families to stay in the community and prevent admission to hospital, as well as increase pressure on the emergency department. Big part of what we're doing also, I think, is trying to support and identify vulnerable families, but with the current workload, that's become more challenging, I have to admit. And then also ensuring that chronic comorbidities are well managed during that period of isolation. So you can see here that the current care protocol, which has recently changed through the New South Wales protocol, and it focuses on a positive RAT or a PCR, and parents registering their RAT in particular, completing an online questionnaire, and then they're potentially being stratified or acknowledged as high-risk children, and that's based on either the parent identifying that they're immunosuppressed, that they have a chronic or complex condition, are pregnant, or severe obesity, or alternatively a risk of hospitalisation score that's coarsely calculated by the computer system. We're finding that is not perfect, so it seems to work a bit better for adults who may have had frequent admissions to hospital or a previous intensive care admission, but actually children are not easily identified through that system. So we recognise that there's going to be a process of self-referral and referral from other practitioners. So the admission criteria for our team at COVID Kids at Home are age less than 3 months, obesity greater than the 95th percentile for age or greater than 30 kilos/meters squared, and then a broad group of pediatric complex chronic conditions. And really that's been defined as needing to see a specialist more than 4 times per year. And we have a particular interest in those kids who may have complex cardiac or respiratory issues. And then certainly asthma, ICU ever or greater than 4 overnight admissions per year. Insulin-dependent diabetes, but also type 2 diabetes, particularly in the setting of obesity. Immunocompromised, particularly if they're actively on chemotherapy, post-organ or bone marrow transplant, a T-cell disorder. But really many of those patients are making primary contact with us or with their specialists that they're known to and being referred through that pathway. And then any patients you might be reviewing who have moderate symptoms, so might be borderline in terms of their hydration, in terms of input or output, have breathlessness or persistent fever. So as I said, really this process relies partly on families self-identifying they're at risk, and why we were carrying sort of up to 500 kids and families across the network originally, and providing quite intensive social support for those vulnerable families. We recognise that those families might be missed. So we're really keen to work with primary care. If you do identify patients who you think are really going to struggle with a period of isolation and the children might be at risk in that setting, to be involved and provide social work and or medical support. So looking at our current data, out of the many kids across Hunter, New England who have COVID-19, there's just 132 admitted. But those 132 are relatively complicated, unlike the previous 500 we might have been carrying. So in that group, there's 35 infants, and there's 25 infants that we're providing active medical input to on a day-to-day basis. So there's 3 very high-risk children, a child with immunodeficiency, a neonate on home oxygen with chronic lung disease in a rural location, a child who's immediately post-transplant for malignancy, and then there's 7 high risk, mostly infants and premature infants, as well as a further child on home oxygen and a child with underlying cardiac disease. In terms of the markers for deterioration and potential need for review in hospital, is really about inadequate oral intake for those younger children. And then in the older children particularly, or in those children who have underlying cardiorespiratory disease, markers of respiratory deterioration, so significant change in work of breathing, breathlessness, limiting activity, low oxygen saturations, and we have been trying to provide oximeters in those over 12 where we think it might be useful, apnea or colour change, vomiting, abdominal pain and diarrhea, increased lethargy, persistent prolonged fever, rash and conjunctivitis that might be markers of an inflammatory syndrome, and then also any cardiac symptoms. As I sort of highlighted in a previous presentation, we're sort of finding up to 15% of young people, particularly females, are having having chest pain, but we've not seen on our service at least serious cardiac events. We have seen a couple of cases of myocarditis and pericarditis related specifically to COVID-19. In terms of disease-modifying agents in children, it's like many aspects of pediatric ID in which there's actually no studies in children. So we are extrapolating and trying to learn from the adult data. and really focusing on the risk profile of these medications and how they might best be applied in paediatrics. And I'll briefly go through these 3 agents, and always happy to be contacted about whether patients might be suitable for these treatments. The first of those is relatively benign, which is budesonide, which you'll be familiar as Pulmicort, and used in adults and used in the adult guidelines. And the suggestion that here from the National Living Guideline is that we use that in symptomatic children and adolescents who do not require oxygen, who are at home, who have 1 or more risk factors for disease progression. So that includes asthma, obesity, and this nebulous group of pediatric complex chronic conditions. We've been really focusing on using it in those children with obesity, and in children with severe asthma, we've really been looking not to start them on inhaled steroids if they're not already on some inhaled steroids, but also really to optimize and increase their dose wherever possible for the duration of their illness. So recommendations are as in adults, but the Pulmicort device is quite difficult to use for some kids. So we've been recommending in the over 12 cyclosinide at the 320 dose. In the slightly younger age groups, again, cyclosinide in this slightly smaller dose. And in the under 5, just simply using Flixitide at a dose morning and night. But as I said, we are really extrapolating that data from the adult studies. And then sotrovimab, recognizing the ICE COMET trial in adults was only in people aged over 18 years of age, but included pharmacokinetic data in children weighing more than 40 kilos. But we are considering sotrovimab for those that are unvaccinated or partially vaccinated, or those that are vaccinated who have significant immunocompromise. And really, we're talking about the group who are actively on cancer treatment or post-transplant, or have an underlying severe immunodeficiency, such as a T cell disorder. There's some urgency to do this as in adults, so aiming to give it within 5 days of symptom onset. And of course, they need a risk factor for disease progression. So where we have given that so far, and we've given 3 lots of sotrovimab across the network in children and young people, an unvaccinated adolescent who had symptomatic disease and significant obesity. And then the other 2 have been slightly younger children who, again, have been unvaccinated but had multiple risk factors for severe disease, and we elected to give it in that situation. And then finally, in terms of disease-modifying agents, remdesivir, an antiviral agent, and really based on a recent New England Journal article that suggested that this could reduce the risk of progression to severe disease and need for intensive care. We've extrapolated that data, really focusing on the under 12 and less than 4 kilos, and using that proactively within 7 days of symptom onset for those children who have really complex comorbidities or significant immunosuppression. Again, not as a treatment measure, but in this setting, but as a prophylaxis to try and prevent progression of disease. We'll just highlight again regarding PIMS-TS. So this is pediatric inflammatory multisystem syndrome, temporally associated with SARS-CoV-2. So COVID infection, which could be completely asymptomatic or simply relate back to an exposure. And then approximately 4 to 6 weeks later, a profound inflammatory Kawasaki disease or multisystem inflammatory type response related to that initial insult. The estimated incidence is about 1 in 2,400 kids. So it's no surprise now as the numbers in children kind of increase across the network that we're starting to see cases filter through. And I just phoned about one before this meeting. That's why I was a little bit late. And we've had one last week. So we're starting to see these cases present. So this was an 11-year-old girl from around the lake. She actually had no known COVID exposure, and she presented to Belmont Emergency Department with acute abdominal pain and vomiting, and was actually brought across for a ped surgical consult with some inflammation around the gallbladder, which you can see in atypical Kawasaki disease and PIMS-TS. Almost during the transfer and then on the ward overnight, which seems to be when all bad things happen, it developed a diffuse rash, fevers and shock, required 80 mils per kilo of fluid, and then ended up in intensive care on a noradrenaline infusion, and ultimately had PIMS-TS related to COVID, previous COVID infection. And she was treated with IVIG, early steroids and some aspirin. Unfortunately, had a normal echocardiogram and went home after a couple of days. So in the younger age group, PIMS-TS tends to present more like Kawasaki, so in the under 5s. When the older group, we're seeing much more of a septic shock or toxic shock type syndrome, in which they seem to be presenting more with abdominal pain, diarrhea, lymphopenia, and features of shock with quite significant myocardial dysfunction in some children. So coming back to outpatient management, so if you do identify patients, you're seeing somebody via telehealth or a family makes contact with you, we're really keen to be contacted and to provide whatever support is necessary for those families and kids. In some instances, you might like them to self-refer, so they can contact, I think it's till 9 p.m, the New South Wales COVID Care at Home number on 1800. You can send us an email at any time if there's a non-urgent referral. And then during business hours, feel free to give us a call on the COVID Kids at Home number. That's 3 to 4:30. That's the number there, and we'll make sure these slides are available. And I think that's also listed on the health pathway. So give us a call if you wanted to talk through a case. That phone is typically answered by one of our senior nursing staff who might be able to help you, but there's typically a paediatrician on site Monday to Friday. And then finally, if you've got somebody who you're really unwell, who think is really unwell, who might need to come to hospital, or you're wondering about PIMS-TS, we've just activated the paediatric COVID consultant for John Hunter as of Monday. So through Switch, that should be 49213000, you can ask to speak to the paediatric COVID consultant, or of course you're always welcome to speak to myself or one of the other general paediatricians on call for John Hunter Kids. That's my email, but I'm happy to take questions.
Cohen, thank you so much for that. Cohen, are you staying around for the panel discussion?
Yeah, very happy to, Karen.
Terrific. I do have one question I might just ask you, I guess, related to your discussion, and that was the question is about chemotherapy, etc., for up to 5 or 10-year-olds post-treatment. And I guess it was just asking, these children who have actually in that group post-treatment, are they actually vulnerable? Should they be, should they be part of your program, or can they be looked after in primary care if they're post-treatment?
Great question. I think broadly the evidence is that your immune system probably doesn't really return to normal for 2 years after chemotherapy. But there's now great data internationally to say with relation to COVID-19, it's really those kids in their acute induction and consolidation phases of chemotherapy. So it's really those high risk periods where they'll have febrile neutropenia that they're most at risk. So any kids that aren't on active treatment, happy for them to follow the low risk community pathway.
Terrific. Well, thank you very much, Cohen. And it's actually my turn to speak now. And I thought I'd give a little bit of a general practice view and a Central Coast-centric view to living with COVID. I'm going to share my slides now. And just asking, can you see my slides?
Can.
Thank you.
Thank you. So, welcome everybody. I'd like to pay respect to the land that I am speaking from, which is Darkinjung land on the Central Coast. And you can actually see my slide there, which is a COVID sunrise from Avoca. And I'm just having a little difficulty getting back to my slides, so I will just get rid of the questions and come to my slides. Okay, So I'm going to just cover, I guess, quite briefly, a Central Coast perspective of COVID care in the community. And so I just want to go through, I guess, a GP's observations. I've been speaking to many GPs across our area on the coast about how they're managing in general practice. I want to just talk a little bit about RATs and PCRs in general practice. About performing a RAT in general practice land. I thought I'd go through, just touch on the Central Coast pathways for GPs triage of moderate to high risk COVID patients, and looking at the Central Coast COVID Community Support Team and the paediatric team on how to escalate care for GPs, and just a little bit that's come out of the PHN for GPs and what we're going to be looking at in the future. So I guess my observations and those that my colleagues are talking to us about are that we're amongst a tsunami of Omicron, which of course we've all known that there's 90% of COVID in the community is due to Omicron. And usually it's a mild disease, and we are finding that the majority of people are self-caring. But probably one of the biggest issues about having COVID is self-isolation, feeling alone and very fearful, and what next, because they've been watching what's happened over the last 2 years and very scared what's happening at home. I guess the issues about rats being ratted, whether we've got a positive rat, and I guess from our perspective in general practice is we now, from yesterday, it is a public health order that everybody who tests positive with a rat actually self-identifies through the Service New South Wales app. You can do that on behalf of anybody else as well. It's quite straightforward to do so, and they're asking for everybody who's had a positive rat since the 1st of January to notify, and that will then allow access to the text message from health, which will give access to care for people in isolation. So rat positive or PCR positive is now COVID-19 positive. The date of the positive test, whether it be a rat positive or PCR positive, is day 0. And in New South Wales, as John Ferguson was saying, that the de-isolation for a person who is asymptomatic is midnight on day 7, as long as their symptoms have resolved. So there is New South Wales New South Wales Health have declared yesterday there'll be a $1,000 fine if you don't report your rat, but it sounds like this is more a threat of a fine as a stick rather than actually being happening. Pretty much from now there'll be no further contact tracing, although I would like John Ferguson's opinion about that. We're talking to Kat Taylor yesterday, that was her opinion. They just can't cope with it. We know our workforce is in crisis. We know that healthcare workers are being furloughed, both in primary care and across general practice, and all our colleagues are doing it pretty hard. And I guess just importantly, that booster shots are our best offering to reduce the risk of severity of infection against all strains of COVID, including Omicron. And we should be really actively promoting a booster shot. So it's just very briefly about rapid antigen testing, what came out yesterday. What will happen is that once a person declares their rat positive on the New South Wales Services app, that they will receive a text on day 1. And that is just after midnight on that day that they get their positive test. And the de-isolation date will still be after 7 days. It will then go to Medibank triage system, and then for those, and there'll be a questionnaire for the patients or the person who's positive to identify their risk, and then that will be upscaled to the community care support groups, depending on the person's postcode. I've just got a little thing in here, and I'll talk about that in a minute, is that there is on the Central Coast Health Facebook site a wonderful video that Kat Taylor just put up yesterday, explaining a lot about rats, and it's really helpful for your patients to perhaps have a look at that. Okay, sorry. So this is just the Medibank triage. So patient on the left-hand side of the box, patient registers as a positive rat on Service New South Wales. That then goes up to a system which is held pretty much by New South Wales Health, and the patient receives a self-managed and de-isolation SMS. Medibank then contact cases classed as intermediate from their questionnaire that they fill out, and they're classified as 3 different groups. The majority of them will be patient self-managed care, community team contact above that, and urgent medical attention required, where Medibank will identify those who may well require urgent medical attention. Call an ambulance on behalf of the patient. So this came from Kat yesterday, and John Ferguson did indicate that we may not need to follow this, although this is still, as I believe, still in play, that a positive rat, what do we do next? It says that you do not need to have your rapid antigen confirmed by a PCR unless you're pregnant more than 20 weeks. At the moment, our First Nations are on there, but that is a little arbitrary, and we certainly don't want to discriminate against our ATSIs, so we do need to be a little aware. If they're well, they probably don't need to. Those who are unvaccinated in the over 16 years, immunosuppressed, a worker, resident, patient or client in a high-risk setting, or asked to by a registered medical practitioner. There is the site for the Facebook communications. I won't go that live, but it is live, and it's a really useful site. We perform rats in general practice, in our practice, and the reason we do, and we have done for quite a while now, is to look at a bit of safety for us, particularly in prolonged consultations. And again, I've just lost my slides, so I just have to find them again. Okay, we actually do it because we are a practice that provides a number of long consultations over 15 minutes, such as a skin check that might be very complex, an IUD insertion, complex skin excisions, face-to-face counselling, vasectomies, that kind of thing. Perhaps a patient's having an iron infusion, and we also perform a rat test for a patient with respiratory symptoms who has not actually had a rat performed beforehand, and I am struggling with seeing my slides, I'm very sorry. So therefore, but we do that dressed in full PPE. Now you can see in the bottom right-hand corner in my practice, I've actually brought in a demountable at the beginning of COVID in 2000, and that's where we've done all of our consulting of our patients with respiratory illness, and therefore we can offer care for our patients who do have respiratory symptoms and identify whether they're COVID positive by a rat test. We actually charge our patients for the rats just at cost. And we do get consent before we do so. If a person is symptomatic and presents to us with a negative rat, we usually do a PCR for them. Now, Central Coast people, this is the Central Coast Health Pathways. It can be a little confusing because there's a lot there across the state. Just again, reiterating, Central Coast Health Pathways, username Central Coast, password OneConnect. The 2 areas that I use often is the COVID-19 shared care in the community site. That will give you all the information you need with the red flags, and then running through what happens for referrals on the Central Coast. I'm going to give you a cheat sheet in a minute. Testing, referrals and advice as well is the second one that I use a lot. And just to get you to note that there is a clinical editor's note at the very top of these pages now that to show any changes. So any new features actually are at the very top with what's changed, read about new and important change to the drop down. So these are all groups on the right hand side. You can see that all of those are active. And again, I use shared care in the community and testing, referrals and advice. This is my cheat sheet. How to escalate care in the Central Coast to community support team. What happens is that the Central Coast COVID community support team will receive notification of all moderate to high risk positive patients, whether they're PCR positive and identified by their hospitalisation or through the Medibank triage process. And these are 3 simple ways of triage for a GP who needs to get some assistance for a person who either isn't part of the moderate to high risk positive patients or you're not sure you need some help. And the team have assured me that you will actually get an answer to an email if you actually put your email referral through to that email address. Or the supporting medical officer holds a mobile phone 24 hours a day. It's not to be given out to any patients, and it's 0487120324. Or the paediatric remote monitoring team for any children. That is manned from 8 AM to 8:30 PM, 7 days a week. And that is 0487082823. I have rung these numbers a number of times in the last 2 weeks and they are getting answered and the emails are getting responded to. Now there is a referral form to email as well, and that is very useful because it assists in giving all the patient's details. Now that form is actually an attachment to tonight, so if you could look for that as one of the PDFs there. I will actually make this available. This is my cheat sheet. I use it all the time, and it is the way really to communicate to escalate your patient's care. They identify everybody who, those who may need to have sotrovimab. They have infusion clinics now through APAC on a Tuesday and Friday and soon to be on a Wednesday. And any patient attending the emergency department who meets the criteria for sotrovimab can be given it in the ED department. The CCST team will actually provide an oximeter to a patient. They courier it to the letterbox or doorstep, and then they pick it up at either de-isolation or as the patient has improved, and they actually are reusing them after they're being cleaned. They will also provide medication packs in adults. There's salbutamol, budesonide, puffers, paracetamol, ibuprofen, and kids there's salbutamol and spaces, paracetamol, ibuprofen and hydrolite. And these are for children and adults who may not be able to get access to a chemist or in the after hours period, and they again land on the patient's doorstep within a couple of hours of being requested. So you can request that for your patients if you need. At the moment, they're getting calls, and really they've only been having about 5 to 10 calls from GPs a week in the last 2 weeks, which I'm quite surprised about. I think there's been about 3 of mine. And certainly moderate to high risk children are those who are under 3 months of age, and I believe that will soon be under 1 month of age with chronic disease immunosuppression. Those people with pregnancy and First Nation peoples and chronic illness will automatically come under CCST, but they may not be there, so you do need to contact the team if you need. Just some news from the PHN. We put out a survey that we've asked all practices to look at providing the children's 5 to 11-year-old vaccinations. So if you could do that survey, it only takes you a couple of minutes. PHN are getting some pulse oximeters so that we can utilise those in general practice, and they will be available from each office. There is going to be a form, and I think John Bailey has already organised that to get access for these oximeters, and we'll let you all know that. Rats are being distributed to aged care facilities by the PHN and soon to come into vulnerable communities as well. There's also an EOI out to manage COVID positive patients in general practice, and those practices that have done those EOIs can get access now to PPE bundles, and those email addresses are there. Remember, you will get my slides, so you can actually open those for those practices who are have done the EOI for face-to-face, or who have done the EOI for virtually and seeing other patients with respiratory patients. There are bundles of PPE available. We've formed a GP COVID panel, and most of our speakers tonight, the GPs, are actually on that panel. So that's actually in all of your areas. So if you've got any questions, as John Bailey said at the beginning, please pop those up and give those to us, and we will try and get the questions answered during the week. We're going to try and have a COVID update webinar every 2 to 3 weeks. With that portal. And just to plug, LHD Central Coast has actually put out an EOI for GPs to join the COVID community support team. Professor Stevie Chen has requested that. There's a live EOI out. If you haven't seen it, we can send that out to you as well. But I would highly recommend. None of us are going to be able to provide that care, that access to that team on a full-time basis, but perhaps a shared care program might be quite useful. So that's all my slides. Now I am going to hand over to Jo Wood.
Thanks, Karen. Just get my slide to behave. So I'm just going to whip through a few of the Hunter New England changes on their community health pathway site, and also just outline some of the changes for the COVID care in the community team for adults. So give you a quick overview of the current service, describe the referral criteria, including the local indications for sotrovimab, and describe the clinical support options we have for GP-led patient care, and the health updates. So I'm just going to give a bit of context with thanks to Dr. Li Fong for providing these on a voluntary and daily basis to our Hunter GP Association. He's been keeping us up to date with the numbers locally. So we've got the green line showing us the new cases there. We've got the orange line. So back there, the orange line is nice and low compared to the new cases, but that orange line is still very high, and that's the current hospitalizations. And the caseload there is sort of in the yellow, which has led to some sort of a bit of a shuffle with the people that are coming onto service with the COVID care in the community team. When we had our original outbreak with in our current structure with all of our GP VMOs who are participating in the roster, we were trying to do pretty much an all-encompassing, everybody that gets COVID will get onto service, and we'll try and keep an eye on you and do a monitoring-based service. Clearly, that was never going to work with this new outbreak, and so there's been some quite hefty refining of the criteria of people that are going to come onto service, very much as sort of Cohen outlined with the new ACI guidelines, but just with some local specificities, trying to really sort of narrow down the groups that we think we may be able to assist with hospital avoidance and early intervention. Now I'm going to screen. Is not, but here we go. So we've got the main focus really of what we're trying to do now is to really try and pick up the people that we may be able to get sotrovimab for, and then monitoring a smaller group of people with a very, very high risk of hospitalisation. And over all of that is to be hopefully offering some support to our GP colleagues who are going to be managing a much larger cohort of people in the community. So we're handling a lot of calls at the moment around that sort of support. So 2 questions asked. So who should be referred for intervention and who should be referred for monitoring? The indications of sotrovimab are in the community health pathway. So at the moment, the current sort of parameters that we're using is adults and pregnant women in their 2nd or 3rd trimester within the first 5 days of their symptoms. It doesn't matter about the severity of those symptoms, just got to be sort of early in the disease course. And then the list of the people that we would consider initiating the sotrovimab for would be the unimmunised people that may have diabetes, have a BMI greater than 30, chronic kidney disease, congestive heart failure, chronic obstructive pulmonary disease, moderate to severe asthma, age greater than 55 or age greater than 35, Aboriginal or Torres Strait Islander. So now that group has almost disappeared because of our really high vaccination rates, and the majority of people that we're organising sotrovimab for are people that are significantly immunosuppressed. We've just developed a list of people, and that definition of immunosuppression is in the health pathway and worth having a look. I think that will probably get refined over time. Certainly that's sort of where we're trying to target our work. Over the last couple of weeks, it's been with the lags of PCRs and getting people onto service. It's actually been an interesting phenomenon of people being at day 4 by the time we talk to them and actually being recovered. So that's had a different spin on things, but certainly the people that we're picking up now are frequently through GP referrals. So somebody has worked out that their patient is COVID positive and that they're on on active cancer treatment or something like that, and they've been calling them through to us to let us know about them, and then we've been able to facilitate the referral through. So the very high risk of hospitalisation is, we've narrowed it down to a group with active cancer, people that have got transplants, pregnancy, and then those sort of immunosuppressed people that, which is a very, very broad brush, but using the box 1 and table 1 of A of the ATAGI recommended recommendations on the use of a 3rd dose of COVID-19 vaccine. So that's another little guide that we're using as well. Clearly that's not going to capture everybody that gets sick from COVID-19, and there's going to be instances where you think that you may not be able to monitor your patients successfully, and we'll definitely be happy to have those conversations with people as we're trying to work out how we can best help prevent hospitalisations. But really, most of our service has been around that 7-day isolation, the isolation period, which is now shifted down to a very narrow 7 days, and that's fine for people that are sick and then get better and they're well at that day 7 point. But day 7 is if you're sick, then you may need ongoing monitoring, and that's really where I think probably most of the activity in general practice will be as well. So the people that come onto service, we invite them, as Colin was describing in his presentation, to download an app called Care Monitor, and they would do a daily sort of symptom checker, and they'll let us know how they're going. When there's really high volumes of people on service, that's very helpful so that it can help us target those that are flagging, and really the critical clinical signs is looking for sort of oxygen desaturation. But often the other reason people are presenting to emergency departments and sometimes being admitted is that dehydration from diarrhea and poor oral intake that Colin was outlining before as well. So the mass monitoring that was happening for the Delta outbreak was a much smaller and more manageable number really in comparison. And then sort of at the beginning of this outbreak, we were doing really large numbers, but it really wasn't necessary to do that monitoring for a large group of people. So we're just really trying to narrow it down to those people that we can keep an eye on and offer some clinical support for as well. So I think this is a question that, with the previous outbreak, we were, as GPs, sort of relying on the fact that people would be getting pulled into service and we didn't need to refer them in. That sort of proactive pull will still happen, but it's going to be a narrower group, again, trying to really target those people we can try and get some intervention for. There's this risk of hospitalisation score, which Cohen sort of discussed before as well, and that's based on presentations to to hospital can be a little bit crude and sometimes can miss people that are being really well managed by their GP in the community, for example, if they haven't had lots of presentations. And certainly we've had a few, like the immune compromised people that are getting referred in wouldn't necessarily have been picked up by this screening. So that referral in process is actually really critical. So yeah, we're going for people that have had lots of presentations to hospital and an age greater than 50, lots of presentations to hospital and unvaccinated, our Aboriginal and Torres Strait Islander community with an age greater than 35, and that's based on discussing with them and unvaccinated, sorry, if they would like to proceed to a sotrovimab, and the over 80-year-old age group. So the ways to contact the COVID Care in the Community team is actually it's going to change, next week when we're sort of anticipating a really large influx of referrals. So there will be a shift in the number, but that will be updated on Health Pathways straight away. At the moment, there's the 2 phone numbers for the GP clinical advice line and the email that we're receiving referrals through. There is an e-referral form that is actually probably the preferred way to get referrals in because it's nice and controlled. So yes, if you've got the opportunity to do that, that would be fantastic. Now in Health Pathways, there's like changes all the time. It's very difficult to track sometimes. There's a clinical editor's note at the top of the pathway, and probably the thing to read just periodically to keep yourself up to date with what's going on. The big thing that I wanted to draw attention to, and will be brought up shortly by the lovely Michelle Redford, is a frequently asked questions that she, for general practice, that she has pulled together, and it's popped up there at the top of the clinical editor's notes, and just really as a different way of, and I think really reflects how all GPs are thinking at the moment. What about this? What about that? And it's just a useful tool to have a read through. So I'm going to keep it brief today. What happens next is an interesting question. Certainly the focus with general practitioners getting kids vaccinated and boosters done is fabulous and fantastic. Working out how to monitor our own patients in that general practice space as well, wearing our PPE, all of those things still to come. All right, I'm going to hand over.
Thanks, Jo. And we might go directly to Marie Puxty. Thanks, Marie.
Thank you. Can you see my screen?
Yes, we can.
Okay, I can't. Just interesting. How do I do that?
It is one of the difficulties. Just got it?
Yep, that's okay. Excuse me, will I just fix this? Okay. So thank you very much for quickly giving the opportunity to speak. I will be quick. So I'm a GP in Armidale, and we've been having lots of meetings in the New England Northwest region on a weekly and never-ending basis about how we're going to manage COVID in the community. But one of the things that we've really been concerned about is the vaccination clinics for children aged 5 to 11, and how are we going to manage that because of both the numbers, geographic isolation, limited resources from a general practice perspective, particularly in the more rural and remote communities in our region. And so really this is more an ad than anything else, because I want to tell everybody about a program that we are about to develop, or we are in the process of developing, which is a partnership with UNE Life, the New England Division of General Practice, Hunter New England Central Coast PHN, and the local health district, Hunter New England Local Health District. And what we're planning to do is to have a series, hopefully, of mass vaccination clinics for children aged 5 to 11. The first one will be on, the first weekend will be Saturday and Sunday, the 30th of January, and then be a follow-up one 8 weeks later on the 26th, 27th of March. Basically, we're asking for general practice support, primary care support for this event, or for these events, which is what we hope to, We know that there's about 3,000 children in the 5 to 11-year-old age group in the Armidale and Uralla local government areas. And we think with the fantastic event organisational ability of UNL Life, that we can deliver something like 1,500 first Pfizer vaccinations in Armidale across that weekend at the end of January before the school term starts. So we're hoping that we might even be able to vaccinate half of the kids of this age group in this community. So that's our hope. And so really this is me sort of telling you about this project and asking for help. So quickly, it's Saturday the 29th, 30th of January, follow up 8 weeks later. It's at Sport UNE. It's a walk-in clinic, no bookings required, completely covered by Medicare, will run from 9 till 4 on both days. There'll be entertainment for children, and there'll be education and question and answer for parents. The nominated GP for the child will be informed of the vaccination. Vaccinations will be entered on air within 7 days. There will be translators present for the Yazidi community, which is a big refugee community in the Armidale region, and St John's will be there post-vaccination. Sorry. Sorry, Jenny, I can't seem to make my slides.
Marie, it's Karen. If you just go into your presentation, right down the right, down the very bottom, there's actually like a screen. Yep, where you've got that, click on that. And that go into slideshow. There it is.
Hopefully, yep, there we go, yeah. Thank you.
Yeah, right-hand arrow, and it should bring you across to your next slide.
Thank you very much. So what we need is some workforce. And we'd like to, UNE Life would particularly like to include primary care workforce in the vaccination days. GPs will be paid a flat rate of $1,000. Nurse vaccinators will be paid very handsomely. We need about 15 clinical staff per day to be successful. So we need about 4 to 6 GPs and 10 nurses to do a 2-day vaccination clinic. Food, travel, accommodation will be provided. Obviously, you must have undertaken the childhood the pediatric Pfizer vaccination module. The PHN is providing a lot of financial support for the event, which is fantastic. And we want to emphasise that any profit that's made by UNE will be reinvested to fund undertaking mass vaccination clinics in the smaller towns in the New England Northwest region. So the other thing that we're hoping to do is, if we get sufficient support for this, and we've already had quite a bit of support, to be honest, and some significant enthusiasm from local GPs in this region, we want to try and offer mass vaccination services for the paediatric Pfizer and potentially adult Pfizer booster clinics to other small towns in the New England Northwest region if there's enough interest. UNE Life is already organising in Armidale a walk-in, no booking booster clinic for adult Pfizer doses for the Saturday the 5th of February. So really, if you or your staff would like to be involved in these mass vaccination clinics, or you're a GP from a small town or smaller town than Armidale is what I'm referring to, and you would like to try and see if UNE Life can come and help, then if you could either contact myself or David Schmood, who's the director of UNE Life, and I've put his contact details in the chat as well. UNE Life has already delivered many thousands of vaccinations in their previous mass vaccination events for the primary COVID vaccine courses, and really it's a matter of us trying to deliver as many vaccines for children as we can so that I think all GPs, but often rural GPs, because we are inclined to be rather under-resourced, can concentrate, I guess, on our core business of primary care and, as is appropriate, concentrate on the booster doses. So that's really all I wanted to say. Thank you very much.
Thanks very much, Maria. It's a wonderful initiative, and a call out probably right across the PHN. I guess if you've got some of those weekends free, you're a GP, you've got some nurses who are doing nothing, twiddling their thumbs as general practice is supposed to be doing, not really. We might be able to help you, Marie. So a call out to everyone online to help in your great initiative. We're going to hand over to Michelle now. Michelle, thank you.
Thanks, everyone. Hope you can hear me. Great to be here. I don't think you need to actually see me, so I'm just going to present incognito for now, if that's okay. So I'm a GP at Blackbutt Doctors in Newhampton. I'm the GP lead for living with COVID at the Hunter New England Central Coast PHN, and as Karen said earlier, I'm part of the panel of GPs involved in that. So I'm just going to be talking mostly about changes. This is kind of what my inbox and also my brain has been feeling like recently, and acknowledging that the PHN is making a change a bit to how we do things. So one of the things, as Karen said, is that we're moving to do more regular updates, and also that we're going to try and capture your questions and answer them in one place. So this is the links. So these will link you through so you can ask your question anonymously. And those will all be hosted on one of the PHN websites, and the link is also on Health Pathways. And I think hopefully that will become a resource that you can use. Look, it's going to run as a little bit of a trial over the next 3 months or so, and then we'll see how it goes. Initially, the focus is going to be on sort of GP practice nurse type questions. I think, there obviously is a wider primary care community of allied health and specialists and all sorts of other people out there. Initially, we are focusing on GP practice type stuff. So this is what it looks like on the website. Oh, sorry. And then that's just showing you again, Health Pathways remains your encyclopedic source of information, and those are the 2 different pathways available in our region. So you should hopefully have those saved on your desktop and know how to get into them. So this FAQ by no means replaces Health Pathways, it's just trying to keep us up to date with all the changes. So what's changed in the last 3 weeks? So we had a little webinar before Christmas, and it felt overwhelming then. And now we've had 3 weeks of all of this. So we've had, as other people have mentioned, explosion in numbers, movement to self-management, because hospital in the home can only, of course, focus their attention on the most at-risk people. The escalation pathways, have been not always completely clear to everybody, and then all of these other things. So I'm going to talk about some of the things in red. Look, we haven't got lots of time, so I am going to rush through some of this, and I'm happy to take questions, okay? So let's just go. I think just a bit of reflection about what we're doing in primary care, because we're in crisis mode now. Certainly in Newcastle, where I practice, there are thousands of cases of COVID, it would seem. And I think we really need to be shifting our thinking into how we maintain service and how we do the most important things. So I'm going to be talking a bit about team safety, service continuity, not so much about self-care, because you all will have to find out ways of doing that yourselves, but really about those practical things in practice. The main task, I think, is for us to identify who needs urgent help. And I think we need to just remember that there are people who need urgent help who don't have COVID, and that is still our core business, and we don't have an opt-out for that either. So we still need to be able to provide that service whilst identifying those people who we do need to then forward on to COVID care in the community and COVID kids at home for more monitoring, or also sotrovimab or budesonide, but also, who needs to call 000. So what I'm trying to do, and it's kind of reactive rather than proactive, is say to my patients that I would be worried about, if you get a positive test, then you need to let me know, and I am interested. You know, I don't want to find out 5 days later after you've missed your sotrovimab window. So then the how to sort that, I think Karen covered that for the coast, and I think Joe has covered that for Hunter New England. Then the other roles are encouraging self-management, reassurance, and continuing to vaccinate. So these are the sorts of things I'm going to be talking about. So how do we reduce the risk of closure? Look, I think lots of you have already done lots of these things. I'm like a broken record on the old PPE front, but I just want to bring your attention to the tea rooms. So we will all be coming across people who've got COVID in our home lives and in our work lives. I think you know, your chance of catching COVID from a co-worker, if you're wearing PPE when you see patients, is probably much higher than it is than catching from patients. So the tea room is the only place where potentially people are not wearing their full mask and eyewear, and so I think we just need to be aware of that risk. So this may also be a familiar slide. So this is really just to update you on what is happening if you have a contact in your practice. So you may get case alerts from Services New South Wales still saying there was somebody at your practice. I mean, that's a low risk sort of contact. You don't actually get any more information about it because contact tracing isn't really happening in the same way. So you're not going to get contacted by the public health unit like you might have done sort of 3 months ago. And so you're also not going to be sort of shut down or anything else like that. But if you get your patients to wear surgical masks, and if you wear eye protection within 1.5 meters of a patient, and if you wear a P2 respirator when you're seeing respiratory patients, then there really is very little action as a result of a COVID positive person coming through your practice, other than checking your procedures and making sure that they are all up to date. What about patients? If you have a COVID positive patient through the practice, again, like it would be pretty hard for another patient to become a close contact or anything else like that. I will talk a bit about close contacts in a sec. So that's the matrix for the patients, and this is what is required of those people. And we want everyone to stay in the low risk green area. Anyway, I can talk more about that if people are interested. This is my matrix by role, what PPE should be used, what is the absolute minimum. You can argue down here in the red box at the bottom under other clinical staff that they should all be in a P2 N95, you know, that will give you a high level of protection against COVID, but in terms of not being sent home and having to test, a surgical mask, if you're someone who doesn't have household contact and doesn't have respiratory symptoms, will be sufficient. These are our screening questions. Probably everybody has reviewed these sort of things recently after all the travel and have you been to a contact location stuff just sort of evaporated. So workplace issues, I talked about alerts in New South Wales app. These are the common things that people are asking about. What do you do with a COVID positive staff member? What do you do if a staff member's had COVID exposure outside of work? I will talk about that a bit. So this is the sort of rules. So if you're a COVID case, you have 7 days isolation, then avoid high risk settings for a further 3 days. And you know, you could argue that general practice is a high risk setting. Aged care facilities definitely are a high risk setting. If you're a household contact of a positive case, 7 days isolation from the last contact with a positive person. So if you're not isolating separately from that person and you are still having contact, you may end up with really quite a prolonged isolation period. And then household contacts also have those testing requirements. They also, once they've left isolation, have another 7 days outside of a high risk setting. There's a bit of talk and discussion because of the New South Wales Health Directive about healthcare workers who are essential can potentially return to work with risk mitigation in place, which is constant P2 mask wearing and frequent testing. You know, if you're a GP and you can work from home, then maybe that's a safer risk strategy. But I can provide links to those guidelines, and they are on the FAQ. The other part is that you get a free pass for a month after you've been de-isolated from having had COVID, and you don't have to be retested in that time, and you can't become a close contact in the same way in that time. And that whole thing that caused some headaches a few months ago about secondary close contacts is not really a thing anymore. De-isolation, there's lots of questions about this. Look, it's routine de-isolation day 7 for asymptomatic cases who are on self-management. We shouldn't be having to prescribe those medical clearance notes anymore. I had a big flurry of those before Christmas, but generally those wouldn't be needed, and I don't think we should be shifting day 0s particularly either, because it's difficult to prove and it just creates lots and lots of work for us. So if you want to discuss that in more detail, maybe in the questions, because I'm just going to skip through some Medicare stuff. So the phone item number for more than 20 minutes has gone. It only exists if you're really way out west in MMM 6 or 7, and for the rest of us, there is only the item number up to 20 minutes. Remember, the 12-month rule for having been seen face-to-face doesn't apply if the patient has COVID, but it still applies if you've got COVID and you're at home and your patient hasn't been seen face-to-face in the past 12 months. So you can't get a you can't get a rebate for the patient in that situation. This $25 face-to-face thing that has caused lots of interest and confusion. At the moment, the Medicare item number still says that they have to have a confirmed laboratory test. I don't know if they're going to change it with RAT. It's only $25. I think most of us are probably not planning to see them face-to-face, but maybe end up seeing them face-to-face accidentally. You don't have to bulk bill for COVID care, and the 30-20 rule, which was threatened to come in at the beginning of January, has now been deferred to the end of June. That's where if you bill 30 or more telephone, not telehealth, so video is exempt, but telephone consults on 20 or more days per year, you win a Medicare audit of all of your practice, not just your telehealth and telephone. So that would be something I would suggest we would like to avoid, but hey, we're not getting it until the end of June. Karen touched on this. You can now, it went live, it seems to work. Happy days, you can update your positive rapid antigen test, and about 50,000 people did, I think. And that's what it looks like. So there is this little bit of disclaimer and things. Okay, so on to vaccination, mandatory vaccination. So this started quietly before Christmas, and all of us and all of our staff are stage 2 healthcare workers. That means that everybody has to be fully vaccinated, so have had their second dose by the 28th of February. So you may be getting some more requests for exemptions, but that's the new rule for the whole of primary care, and it covers a lot of other people as well, including various allied health professionals who are also regulated by APRA. Boosters. So boosters are just for people who are age 18 plus. It's either Pfizer or half a dose of Moderna. Please no AstraZeneca. AstraZeneca is not preferred. We're currently giving them 4 months from the second dose. Atagi has approved it for 3 months. It's just that the vaccine rollout, is prioritizing the people who are 4 months now, and then we'll get the official go, I think, to be 3 months from the end of January. This includes people who received 3-dose primary course, so that is a change because originally they were excluded from boosters. You can give a booster vaccine with other vaccines if necessary. And there is this extra item number for the extra $10 for a booster, which is a Medicare billing number, and you bill it as well as your item code when you do dose 2. Oh, sorry, dose 3. It's the dose 2 code, but you bill it when you're giving dose 3. There we are. Generally, just defer for until they're better from their COVID. Look, it's not a priority to go giving these people their booster just straight after recovery from COVID. So some places I'm seeing it written a month after recovery, after they're well. Some places just when they're better. You certainly don't need to postpone it for the whole of 6 months. ATAGI does recognise that it can be deferred for up to 6 months, but it is suggested that it is given before that point because, you know, they could get a different strain. So they could have had the current strain and then they could get Delta, and that's no good. If they've had sotrovimab or other monoclonal antibodies, you have to delay it by 3 months. Vaccine exemptions on the AIR. So hopefully we're not doing lots of vaccine exemptions. I guess there will be some people who might need a vaccine exemption because they're covered by the mandatory vaccination and they've had sotrovimab or something and they have to have a 3-month window before they can be vaccinated. So those sort of things can happen. You can do them directly on the AIR, and these are some screenshots of me playing around. These are the criteria, and so you can see you can't put a permanent exemption unless you've had previous anaphylaxis or this significant immunocompromised, which, sorry, I didn't mean to do that. And I think individual who's pregnant doesn't actually count as an exemption anymore. So there is some extensive guidance from ATAGI on this, and the people who are eligible for a permanent exemption are very, very few and far between. Just to confuse us more, the New South Wales vaccine medical contraindication form is different, but that's what that one looks like. So you don't have to do both, you can do either or, but I think that actually the New South Wales Health one's a bit easier. They're going to be not lots of people. Pediatric vaccines causing confusion. The pediatric vaccine is in the orange topped vial. The adult vaccine is in the purple top vial. The date on the box is the thaw-by date. The date on the vial is the date it was manufactured. It doesn't have an expiry date on the vial. So this vial was manufactured in October 2021. That means it expires on the 31st of March 2022. Its use by date from thawing is the 14th of March. So we have to use it by the 14th of March. You just have to use the earliest one, but it is quite hard to find the manufacturer's expiry date. If you can't work it out from looking at the vial, it is on the delivery acceptance forms in CVAS. It's different to the adult Pfizer, which actually shows the expiry date on the vial. It's just to confuse us, but we're wise to it, so that's what's happening. You do need to complete the mandatory training to do pediatric vaccines. Please complete the PHN survey so we can get an idea of where support's needed. This is just a run through of the vaccines. We're sometimes getting 11 doses out of a vial, that's good. Dose intervals 8 weeks. We're not moving to 3 weeks. Kerry Chant said in the webinar for the RACGP on Monday that we're not doing it 3 weeks yet. If the child turns 12 between doses, you give the adult vaccine for the second shot. So if you're 11, nearly 12, you get your pediatric vaccine, and then 8 weeks later, when you're actually 12, you get the adult vaccine. You just get the vaccine that is appropriate for your age at the time. Just to confuse us further, there is no, or there wasn't any actual tickable box in best practice for the pediatric vaccine. You can just code it as Pfizer, as the adult Pfizer. You can write pediatric in the box if you like I have here, but actually the AIR doesn't differentiate between the two, so it doesn't matter too much. Just make sure you got your batch numbers and stuff in, that's fine. And these are some other questions. What do I do if the child jumps away and I only give them a smidge of the vaccine? So that's the ATAGI advice. You give a replacement dose a minimum of a week after the invalid dose. So sorry for running through that really quickly. I'm sure you have got some great questions. Please submit your great questions to the PHN website. We'll get through them as quickly as we can. And after all of this, I will also start doing some little Kahoots to test you and to get you engaged in answering the questions a bit more. Thank you.
Thank you, Michelle, and apologies to everyone that we have run over time, but we're very much hoping that you agree with us that there's so much to share, and our speakers have had so much information that we thought it was worthwhile running a little over time. Now we are supposed to go to a question and answer panel. Can I ask all our panelists just to put their videos on, please? And I guess I just need to ask Can we go a little longer? Yep. We've still got 167 people online, and I am just so pleased to know that you're all paying a lot of attention and asking some great questions. And again, I would really like to extend my thanks to all of our speakers tonight. It's been just loaded full of so much great information. And we have got some really good questions. And I guess I just would like, I guess one of the questions, or a number of the questions, are about rat tests, and where, if for those who are vulnerable, those with symptoms, those who probably do have COVID but cannot get access to testing for some form of reason, is there a way in our PHN footprint for these people to actually get a rat? John Valley, can I ask you that? Is there some way we can get a rat out to our very vulnerable patients?
Thanks, Karen. Look, New South Wales government are currently working through the distribution of rat kits to vulnerable communities. We met with them earlier this week, and they are taking a position to government, and we're hoping that that will resolve the issue for vulnerable peoples.
Diagnose, because these people really do need access to care.
Not sure about others, but I'm struggling to hear Karen's. Yeah. I'm going to turn my video off to ease the load.
Okay, can you hear me now?
Yes.
Just thumbs up if you can.
I've turned my video off, but yes, we can hear.
Okay, thank you. Okay, thank you. So Michelle, we'll keep you, no, Michelle, you stay on. We need somebody's face there. A question to John Ferguson about antiviral treatment, and if other treatments other than sotrovimab, are they being used, and how close are we to having the oral monoclonal antibody treatments?
So there are some oral agents that are not available in Australia yet. They haven't been approved by TGA, and I guess we're awaiting further evidence. Mark Lanthor might like to comment, I don't know. There's nothing really close to licensing.
Mark, do you know anything there?
I think Mark has dropped off.
Okay. It's a question we certainly will put up on our panel and ask Mark further for that. A couple of questions about vaccination, and there on the RAC GP webinar on Monday night, there was a discussion about that maybe once a second vaccination, number 2 in the primary course of vaccines, it's gone past 6 months, stating that you are no longer immune to any COVID. Is that correct? Would somebody like to answer that?
Well, look, that's,
yeah.
I can just comment that it's especially strain specific. So, you know, with Delta, we realized that, and it's vaccine specific too. So with Delta, I think people are estimating a 3-month cut point for market reduction in immunogenicity with the AstraZeneca vaccine. With Omicron, there's far less duration of immunity. So look, it's very difficult to make one hard and fast rule. But I guess 6 months is on the long side, though. You're likely not to have any protection against things like Omicron or Delta at 6 months.
Okay, so booster, booster, booster. And I guess it was covered in Michelle's discussion about the booster and how soon after a person recovers from their infection, we're still getting a lot of information from a few different sources as to whether that can be once the symptoms have resolved, or 1 month. We certainly know after sotrovimab.
I think nothing bad is going to happen if you do it like within the first month, but it's just not that it's it's not a priority, because they're pretty unlikely to get reinfected in that first month. And with the pressure on vaccine clinics, you know, they're not the highest priority. So it's not that you can't do it. It's really that, you know, it's not clinically the highest priority. Does that make sense? So you know, I would just do them when they're due, but I wouldn't be rushing them back within the first 4 weeks.
Okay. There's a number of questions about pulse oximeters and who should be getting access to pulse oximeters. I guess we spoke a little bit about pulse oximeters on the Central Coast and in the Hunter region, and that we will be getting access to some stock from PHN, and I think watch this space, we will have some more information about how GPs can get those. Michelle and Joe, who would you provide a pulse oximeter to? Joe, would you
at
like
the moment, yeah. Can you hear me, Karen? All right.
Yes, I can hear you. Yep.
Karen?
I can hear you.
Good. So currently, everybody that comes onto the COVID care in the community, the COVID care in the community team is getting an oximeter. So that group is getting one. The question is for people like that GPs might be managing in the community. It's I don't think it's very well defined yet, and I'm really hoping that that gets picked out nice and clearly. I think with the hospitalizations and the type of patients that are the adult patients that are in hospital, like for the majority of people, they have a nice mild illness and it's, over and done with, and they don't need to worry about it. But if they've got prolonged symptoms and they've got comorbidities like lung disease or metabolic stuff, so maybe high BMIs and diabetes, that's the group that you might be worried about having a deterioration phase later on. And we were just talking about it before, actually saying that it would be quite useful, I think, for us to have a separate session where we actually talk about the those hospital presentations in particular, just to really drill down what's happening before they get to hospital and how we can really pick them out in general practice and for COVID care in the community as well. So, look, I think that supply, like a public supply for GPs, is going to be a real challenge. And if your practices have capacity to get a stock in, then it would be a really good idea, because it is a really lovely tool to have to really have a bit of confidence about the ones that have symptoms that go on for a little bit longer, but you don't think really need to go to hospital, and you can see that their SATs are nice and stable. So it is a very helpful thing to have. Yeah, sorry, that was not very precise, but I will work on it.
Thank you for that. And certainly on the Central Coast, you can get access for your patient to an oximeter through the community care support team, but you do need to let them know that you have a patient that you've identified will need one. And at the moment they do have supplies, but I'm not sure whether they'll have supplies into the future. That's where hopefully some of our PHN stockpile will come. A few questions about vaccination, and I guess I'm going to open this to the whole panel, is about the benefit in changing the vaccine after a primary dose or 2 doses of Pfizer to a second mRNA dose as the booster. and what's the evidence? Is there evidence that we should be recommending that? And secondly is, when's Novavax due?
So Novavax is with the TGA, and so I don't think we have a date on that. And I think, you know, we just have to get on with the vaccines that we've got. So I can answer that bit.
John
Someone else might answer
Ferguson,
the rest of it.
can you help us with that?
Well, I think Omicron specific data from the UK that I quoted, and you can go to that report, really gives us strong evidence that a messenger RNA boost over an AstraZeneca base is highly effective, and Moderna slightly better than Pfizer, but there's probably nothing in that.
So 2 Pfizers and a Moderna?
That's okay. I think the Moderna's a higher dose, isn't it, of vaccine. I don't know of any evidence really looking at that.
The booster of Moderna is actually half the dose of the primary course. Yeah. And so therefore one little problem that we fell into in general practice is that we ordered 200 doses of Moderna and realized we had 400 that all it would expire in 1 month. So yes, that's just be careful, everyone. You get at least 20 doses out of 1 vial of Moderna for your boosters. It is certainly, we're finding in our practice that people are really keen to get Moderna. They're knocking down our doors. There's a question about sotrovimab and those, I guess, identifying what unvaccinated means. And particularly for, you know, is unvaccinated mean that they've had their primary course and not boosted, or is it that they've had no vaccines so far or only 1? Joe, do you know any about that?
Yeah, so vaccination, 2 vaccines greater than 2 weeks ago, or if you have a significantly immunocompromised person that's only had 2 vaccines, they probably wouldn't be, you know, that would be eligible for their 3rd dose, would definitely be worth running past, because there's a possibility that they wouldn't be considered immune either. Does that help?
Yep. Thank you. Anybody else got anything to say about that? I do know that on the Central Coast, one of my patients was accepted for sotrovimab on day 3 of symptoms, who had had 2 vaccines, was due for her booster. She's coming in the day that she had her positive test, and developed very severe respiratory symptoms because she's quite a brittle asthmatic, and she did have sotrovimab. So now we do need to finish by 8:30, and everybody's been incredibly patient. So we have got about 6 minutes if those on the panel are still keen to stay. We totally understand. We've still got 140 people online, and we thank you very much for your attention. A question here, Michelle, is the risk matrix in general practice. I guess when we do look at it, and this was mentioned at our last webinar, John Ferguson mentioned it too, about surgical masks for your staff and clinical staff and eyewear versus P95 masks and eyewear for face-to-face patient care in vaccination clinics. Michelle?
Yeah, sure. I mean, this is a recurring theme, isn't it? Because it's been one of the key things in general practice. So look, if you look at the healthcare worker exposure matrix and you want to not be getting out of the green, which is the main target, if you get out of the green, then you potentially have testing requirements and have to go home. Then wearing a surgical mask and eye protection within 1.5 meters of the patient will protect you from going outside of the green. So it serves its purpose in that way. Does that make sense? And then actually to offer you better respiratory protection, of course a P2 is going to be better, but how many P2s have you got? So in the end, there has to be a balance between your availability of P2s and the ability of people to wear P2s all day, and the risks. Of course, right now, this is the most risky that it's been in primary care. So it seems a strange thing to start, dumping the P2 and moving to surgical masks.
Yeah.
And if that answers your question or not.
No. Yeah, John.
And I guess the other element of the risk is that the chance that someone coming for vaccination actually has active COVID is sort of not 100% by any means. It's probably 5% even at current transmission. And so that matrix is based upon being exposed to a proven case, not being exposed to someone from the community necessarily. So you've got to dial the risk down further, and the interaction is likely to be short, and not face-to-face necessarily. So you sort of factor all those things together, it's far easier for you just to wear a surgical mask. We've got no evidence that vaccinators have acquired COVID through the enormous number of vaccinations given. So that's good evidence too.
I think you probably get more out of making sure that your vaccinators didn't co-mingle with their masks off,
exactly,
between themselves, than you're going to get from putting everyone in a P2.
Yeah.
We're going to have one more question, and I have to apologise to those that we didn't get to answer their questions. And your COVID GP panel will endeavour to answer the questions that are unanswered tonight and any other questions that you do have. We will put out the QR code to be able to ask questions, and that will be available across our whole PHN. So please ask your questions and we will endeavour to get the answers. But one last one, which I think probably is quite relevant to general practice and those of us who started vaccinating with Pfizer, was that many of ourselves and staff had early boosters. So there was a couple of doses left over in a vial, and we didn't want to throw it out. So some of us were vaccinated perhaps a little earlier than was recommended. Is there a role to have fourth dose?
So there's nothing from ATAGI. There is nothing from ATAGI on that. The only people who are getting fourth doses approved by ATAGI are people who've had 3-dose primary course and then will get a booster 4 months after their 3rd dose. But that doesn't mean that there might be some emerging evidence coming through, which John Ferguson probably be better placed to talk about.
I don't know of any evidence, but I sense that coronavirus vaccination is going to be an annual affair with a modified structure according to what strains are circulating. For sure, we're going to require boosters into the future, I sense, unless it becomes like,
thanks everyone, and I'm very aware of time. I'd just like the panelists, if you could just put your video back on, and we'll endeavour to have our faces on the screen for one last minute. I won't talk for too long. I'd just like to thank everyone and the panel very much for your assistance tonight, and all of our attendees. And I wish you well. We certainly know that it's tough times. School's about to come back in a couple of weeks, and we did have a question about suggestions for schools. Maybe we need to do a webinar really thinking about what we're going to do with schools and how primary care is going to manage within that as well. So I'm going to hand that over to Julie and say good night and thank you again.
Thank you everyone very much for giving up your time. It's amazing to me how generous you all are with your precious time, because I know how incredibly busy you all are. There'll be a very quick evaluation that will pop up at the end. Please take the time to fill it in. We really value your feedback. and this will be on our website in our education library along with the slides. So if you need the information, contact details that Marie had put up, they will be there on the website probably by the end of tomorrow. Thanks everyone, and I hope you all have a good weekend, and we should be back in about 2 weeks, but keep an eye out. The education team will certainly send you an email, and we'll see you next time.
Thanks, everybody.
Thanks,
Thank you,
everyone.
everyone. Good night. Stay well.